I'm Natalie May, and this is my PK talk about examination of paediatric patients. I tend to examine children slightly differently according to how old they are, so I will talk through examination of various age groups and give you some general tips, but here's a rough guide to what I'm talking about when I say babies, toddlers, school-aged children, and older children who I'm going to call teenagers, even though some of them are maybe slightly younger than that. So the biggest tip I can give you in approaching children for examination is to be confident, show no fear and know your enemy. Know what you're up against and what to expect for different age groups, because that can help you to be reactive and to tailor your responses to them if they become upset. Most children aren't going to bite you. Those that do either haven't got enough teeth to do any real damage or need a psychiatric assessment, in which case your job's easy, just refer them for assessment by the adolescent mental health team. Most children are perfectly nice and are helpfully pre-programmed to respond positively towards you if you give them the right cues, so there's nothing to be afraid of. So let's talk about babies. The key feature of babies is that they're small and squashy, and the most important thing is not to drop them, because this tends to go down badly with their parents. When it comes to assessing them, the most useful test you can do is what I call the cuddle test. So while you're taking a history from mum or dad, take the baby from them and give them a nice cuddle. Most babies will snuggle nicely like you can see in the picture, and that'll make you feel a bit warm and fluffy inside. Just beware those babies who are floppy or who hold themselves stiffly and make it difficult for you to cuddle them, because that can suggest there's something untoward going on. This is all about an assessment of the baby's tone, which is sometimes documented as handling well, and this can be a useful component in your assessment of the presence or absence of disease. Generally, babies don't really care who you are or what you want, so it's relatively straightforward to assess them. When it comes to examining them, lay them flat on the bed and strip them off completely. Just be aware that babies can get cold pretty quickly, and remember that from 4 months of age, a baby may be able to roll from his back onto his front, and from 6 months from front to back, so don't put them too close to the edge of the bed, or you might get an unpleasant surprise. I generally examine babies from head to toe, so start with the fontanelle, then listen to the heart and lungs, have a feel of the abdomen, assess the femorals, particularly in newborn babies, and have a good look for any hernias. Make sure you look underneath the nappy, and then turn the baby over so you've looked at both front and back. And you can then get the baby dressed again, and if you want extra bonus points with mum and dad, if the nappy's dirty, make sure you put a clean one on before getting the baby dressed. Toddlers are probably the most difficult age group to examine, and this is because they develop something called stranger anxiety, which means that they know that they don't recognise you, they don't know who you are, and therefore they perceive you to be a threat. The way to get around this is to use mum or dad to your advantage. Generally, if the child looks even the slightest bit like they're going to cry, sit them straight on mum or dad's knee and examine them from there. You can completely ignore them while you take a history, avoid eye contact with them in particular, and maybe offer them a toy while you're talking to the parents. You might be able to examine the toy or examine mum or dad first to reduce their anxiety, but if all else fails, know how you're going to examine them so you can get through the examination quickly and minimise the amount of time that they're upset for. Get mum or dad to strip the child off down to their skin and ask them to hold an upset toddler in this position in the first instance so that you can listen to the chest first, because those subtle chest signs are going to be 100 times more difficult to hear once the child is screaming their head off. They'll generally start crying during the earlier parts of examination and get more and more upset as you go on, so start with the chest, then the heart and abdomen. When it comes to examining the ears and throat, there are particular positions you can use to make things a bit easier. For ears, get the child to sit sideways across mum or dad's knee. Get that near side arm into the parent's armpit and get the parent to bring the same arm around to pin that child's other arm against their side in a firm hug position. The parent can then use their other arm to hold the child's head against their chest to prevent sudden movements. And when it comes to throats, get them to sit with their back up against mum or dad's chest. Get the parent to bring one arm around to pin both arms by their sides and use the other arm to hold their forehead. Sometimes you might actually need to move mum or dad's arms for them. If you're lucky, the child might be cooperative like my godson here and open his mouth to give you a good look at his tonsils. Opening wide like a lion is a useful phrase, but if not, you can wiggle the tongue depressor gently between their teeth to get it far enough back for a gag reflex, which will give you a good view. It's not pleasant, but it's really important, particularly in febrile children. This is the part of the examination most likely to make them cry, so distract them immediately afterwards with a toy or with the tongue depressor itself. School-aged children are a bit of a mixed bunch. There's considerable variation in the age at which they decide they're not afraid of you anymore. Generally, 2 to 5-year-olds will still be a bit wary of you. They might shake hands with you at the start of the conversation, and that's often a good marker of how they're going to be for the rest of the consultation. They might be able to tell you who they've brought with them, and this can help you avoid the sticky, "Is this Dad? No, I'm Grandma" situation we've all got ourselves into occasionally. They might take deep breaths on instruction, certainly from around the age of 4 onwards. You can try it with younger children, but they're quite often not able to do it. 5 to 10-year-olds are generally less anxious. They'll often shake hands with you, and I consider it good practice to give the child an opportunity to give the history in the first instance, or at least to start it off. And they're generally compliant with examination and will do the things you ask them to do. A good rule is to let the child lead the interaction, so ask permission to see their tummy or to listen to their chest. Ask them which ear they want you to look in first. If they say no, explain why. You need to do it to help them to get better. I suggest that you look at mummy or daddy first, show them the otoscope, describe it as a tickle in their ear so they're not afraid, and then give them lots of praise. Really encourage them, tell them they've been clever or brave, and give them a sticker at the end. All that positive feedback will really help. Explain what you're going to do at every stage as well to reduce their anxiety. By and large, examining teenagers is not so problematic because they're a lot more like adults. My big tip is to be professional. Don't try to be too funny or clever with them. Treat them like an adult, and you should strongly consider seeing them with a chaperone but away from family members for at least part of the consultation, especially for older teenagers. Direct your questions and your plan of action to the patient and ask before you do anything whether they're happy for you to talk to them with whoever's come with them or if they'd rather that person waited outside. Be aware that if you do need to have a chaperone, they usually prefer it to be a non-family member, so use a member of nursing staff as you would for an adult. Most teenagers are perfectly able to consent to examination. Discuss with them what they want and respect their wishes, but be careful not to promise to keep secrets on their behalf. There are some considerations we need to make when we see children because we all have a duty to be aware of child protection issues. Be aware of the hallmarks of non-accidental injury and neglect. Be suspicious when you see injuries in non-mobile children. Examine from head to toe any child with an injury, particularly pre-verbal children who aren't giving the history themselves. And remember to think about the interaction you're seeing between child and parents and whether that seems appropriate. And if you have any concerns, you have a duty to act on them. So in summary, children really aren't that scary. You just need to be confident, to be systematic, to be reactive and respond to how the child is responding to you, and use the help available to you, whether that's mum or dad or nursing staff. I hope that's been useful to you. Thanks for listening, and hopefully I will see you at SMAC.